Next, I call upon Dr. Sachin sir to discuss on the posterior pole asymmetric analysis.
Actually, the topic is 3 in 1, no? RNFL, asymmetry, and this thing. Just let me see. So, in short, it is basically everything in a nutshell. We will be going only to the practical points, strictly no theory slides. So, you always remember pattern of ganglion cell death is different for different types of glaucoma, different for open angle, different for acute angle closure. The neuron is the entire thing that you should be seeing, not the head or the tail. So don't see an elephant, you see an elephant like this, not like this. So see from the optic nerve head to the retinal nerve fiber layer to the ganglion cell all at one time. That is very important. So any number of maps presentations that are available, make sure all the 3 are in one map if you have to be reasonably sure. So once you do the BMO analysis, the next thing you do is see the entire ganglion in one picture. So here we have the overview printout in the spectralis, which I'm addicted to once I'm sure with the BMO MRW printout. So structure correlation it is, and that will get all the 3 structures in one. Now let's see how it applies clinically. See, this is what about Dr. Satyan was telling about the statistical parameters. See, you did the OCT because you suspected something, not because you have a machine. That's what I presume. So when you suspected something, look at the area which you suspected rather than looking at the values the machine is giving you. So here I suspected inferotemporal thinning of the nerve fiber layer. I did the test. Here everything appears green. I should be happy. But the moment I see the green color, I will forget that there is a notching here. If you can see, the ganglion cell pi is eaten already. And that's where I was actually supposed to look when I looked at the map and not at the interpretation. So always look at the areas of suspicion and not the interpretation. That is what you bought the machine for, because interpretation is your baby. So simple things. And now when you go here, even if you see statistically, it's just almost on the verge of tilting into abnormalcy. So look at those percentages, percentile values very, very carefully. They will be almost tending to abnormal in such cases. So be very careful and look at this curve rather than the numbers. So inter-eye asymmetry is another thing, 3-in-1 map, that is the glaucoma overview and clinical correlation. Now see, this is a very prototype case. Okay, so you have this right eye of the patient, you have an inferior notch, very, very clear. You see the rim thin inferotemporally, you see the RNFL thin inferotemporally, and you see the ganglion cell knocked off below. The hemispheric asymmetric map is obvious. This map here is the entire the thickness is lost, and this is a pretty open and shut case of glaucoma. So don't fall into the color identification or pattern identification trap. Now you see this here. Here you are suspecting, this is a doctor who came to me, left eye clinical suspicion was there, we did the test. Now always keep 2 maps side by side. Sometimes the value may deceive you. Here we have, again if you see this hemispheric asymmetry, I am not at all impressed by this. You know, most of the time it will be ambivalent. In my 12 years of experience with Heidelberg, this is the most useless map, if I may say so. So see at the other maps, they will give you a lot of information. Here you can have, here you have again inferotemporal thinning, but here again you have a green color. So is it normal? No. Look at the value, 5 percentile. And it is not that it should be exactly here, it can be slightly here also. Okay, so look at this part, in general it is thin. You have an inferotemporal thinning here, and obviously the pi again is eaten here with a hemispheric asymmetry. So very, very obvious. This I call as the 1, 2, 3 pattern. Very, very diagnostic of glaucoma and nothing else. 1, 2, and 3. So on my OPD paper, if you see some patient comes to you, you will see 1, 2, 3 plus. That is this. Very, very simple thing. That means you have done the due diligence of looking at all the 3 structures at one time, and you have done the structure-structure correlation. Now, how inter-eye asymmetry is important? Here you can see both eyes are inter-hemisphere asymmetry. So here you can see both eyes are abnormal. Uh, one eye is slightly better than the other, but this is an obvious defect. Okay, so you have a notching here. Clinically, you have a notching here. Here you have an inferotemporal thinning. The Isn't rule is broken, but obviously there is a gross difference between two eyes. Even if you see the average thickness 224, 187, 103, and 82, and obviously a sectoral thinning with a notch. Now, if you see here, relatively everything is okay, but this map is giving some non-specific information, pixelations, which is not going to really help you in decision making at all. That's why I said that is pretty non-specific for me. I don't see hemispheric asymmetry, but rather I would see the inter-eye asymmetry even in these hemispheric asymmetry maps. So here if you see in the two eyes and as well as in the two sectors, you have a gross difference, and that's the only help of the hemispheric asymmetry map. More than that, I wouldn't give too much of importance. But inter-eye asymmetry, yes. The values will be different in the two eyes, and that will tell me that there is something going wrong. And here again, as I told you, the 1, 2, 3 rule is followed, and this is a classical case of glaucoma. Now, this is the last example, the great Shane Warne, the bowler of the googly. So I just continued with the last MRW example. You want me to show you again the MRW? In this case, I'll just go back to the last PPT, and then you can put this in perspective. So this was the MRW of the last case. Yeah, so all in the green, all statistically normal, all sectors agree, Brooks membrane opening identified properly, termination, vertical, perpendicular, everything fine, everything normal. Okay, so now I go back to the PPT that I am doing right now, and let's see why Shane Warne will be happy. Yep. So now you see this. Upper one green, lower one completely red, ganglion cells gone. Yeah. So what is this? Is this glaucoma? Sorry? Okay. I am very loud. Yeah? Oh, okay. In the recording. Okay, fine. So, is this glaucoma? Is the question. Now, here is where we look at the case in toto. This case was referred to me by somebody. Now, what I didn't tell you is, this patient had pressures of around 30 for the last 6 months, and the patient was not being treated because the cup disc ratio was 0.3. Because the person was treating was not a glaucoma specialist. Now, because it was 30, he said, no, but he had classical biaccurate scotoma. But no, disc is normal. So it may be ocular hypertension. What he did not realize that this is full of disc drusense. Now, what is remaining is the drusense. The nerve fibers have gone. So the machine is measuring the drusense. Yeah. BMO. Yeah, you can. So, but for the person who cannot see the BMO MRW, that's the whole point, right? You don't have the image of the BMO MRW. If you don't have this OCT and you don't have those 12 scans, then you are straight away bamboozled here, like Warne used to do. So here basically the nerve is completely atrophied. What you are measuring here actually is the drusense. The nerve fiber layer is gone and the ganglion cell is gone. So this is actually an open and shut case of glaucoma, and this is basically seen by you because you are actually measuring the drusense, and this is never going to reduce. This will be the same throughout his life. So this is very, very important. Why clinical correlation is important. Irrespective of the device, it is your brain that is going to take the final decision.